So, welcome to the Breast Cancer Rehabilitation and Wellness Summit. My name is Denise Stewart, and today we're going to be talking about the complications of pain. And just because we feel it, I want to know, in the back of our shoulder or in our neck, it might not be what it really is, or it is, and we don't know where it's coming from. So, I've got Ben Boyd, who's a physical therapist and is working in research at the moment in a university in California. And Ben, I got in contact with last year because he's looking at pain and the side of pain, or the side of the brain, one or the other. Ben's going to tell us more. Welcome, Ben.
Thank you. Thanks for having me. Really appreciate it.
So, Ben, you're doing some research on left and right pain, but take us back to how you got there.
Sure. So we got really interested in the idea of changes in body schema and body image, or kind of the representational health of the body parts after an injury. And a colleague of mine works with women post-breast cancer and breast cancer survivors. She's done a number of studies, and we started talking about whether this could be something that is involved or impacted by survivorship after the treatments for the breast cancer. It was quite fascinating based on some of the comments that she would hear from her patients. And I had previously, when I was in clinical practice, also heard similar things. Things like it no longer feeling part of their self, or this language that suggested kind of a disembodiment of that region of the body. Clearly a change in some sensory stuff like numbness and tingling, but even more evocative and more meaningful on the humanistic level of a change in kind of an altered meaning of that part of their body. In fact, some women were even expressing a bit of dissatisfaction or even a sense of betrayal. So it was that language that started us down this road of thinking about what might have changed that we can look at from clinical measures in terms of body image and that body schema, if you will, for the representational health in their brains.
And so, Ben, you've designed a survey based on the NOI. Is that?
Yeah, they have. They're one group that has a platform for testing a task that's thought to get at this idea of body schema. So it's a left-right discrimination task, or some call it laterality. It actually goes by many different names. But the idea of, if I were to show you an image of, let's say, a hand, and you are trying to figure out, the task is to figure out whether it's a left or right, you will theoretically use your own internal body maps as a reference to try to figure out, is that left or right? And often we'll see people manipulating their body in space, or at least mentally manipulating to try to figure out the orientation, reference that internal map, so to speak, to figure out, is this a left or a right body part or hand in that circumstance. So the NOI group has some platforms for testing the accuracy of that and the reaction time of that. And there's quite a bit of research that's come out over probably the last decade, and even before that, on the impact of pain, different pain states, on the ability to do that task. Which I'll be honest, when we do have an online study platform for it, but we're also doing some face-to-face, and it's a challenging thing to explain. What is it we're even doing with that task? It seems so abstract, and how would this be relevant? But it's quite fascinating, which was what got us all involved and interested in this line of research.
So you've been doing some face-to-face assessments, so what? I know you haven't finished your research, but what are you seeing?
Yeah, and what we haven't analyzed fully is the reaction time and the accuracy of that particular recognition task. But in the face-to-face, It's basically a case series of looking at women from between 1 and 2 months after the completion of their surgery and radiation for the breast cancer, following them over a year's time to see what changes in terms of body image, and we're using a body image scale for that. We're also in that doing a battery of sensory tests to track are there signs that the nerves are damaged or altered in some way. Looking at some movement testing for sensitivity of the nervous system, so through some clinical tests. And so to answer your question, what are we seeing so far? Pretty consistently in the face-to-face group that we're seeing is on the affected side, that there's this heightened protection, if you will, or that's our interpretation of the clinical findings of it takes less pressure on certain areas of that limb and the chest out into the upper extremity to provoke pain than the other side, and then what we would think is normal. There's more of a limitation in the movements that are associated with kind of testing the mechanical stress on the nervous system and how it responds to that. So a little bit more sensitive, a little bit less tolerant on the affected side. But what's really interesting is that following these women after that immediate post-treatment to 6 months to a year out, some of those things are starting to normalize, but what we haven't yet seen is any of the folks that have participated that is completely gone. So there's still, after a year out, seems to be this slightly heightened protection, so to speak, of that side of the body, or that upper extremity, upper quarter, from the chest to the upper limb. So in terms of the recognition task from the bigger online study, what we have looked at briefly, and this is not a very sophisticated dive into the data set yet, but that there does seem to be some alterations in the responses to that recognition task. And what I should say, if I go back up for a sec, is that the platforms for testing have been built out for things like the hand, shoulder, the neck, and some lower extremities as well, and the back. But no one's ever looked at it for the chest or the breast. So what we did was we created a image series of images and created that platform to be able to test it for the first time for the breast or the chest. And that's what I could speak to. We've looked at a little bit so far, and at least as a whole group comparison of over 150 women post breast cancer compared to probably about 350 women without any history of breast cancer, that the accuracy of that recognition task is a little bit worse after breast cancer, not by a great magnitude, but it is statistically between those groups looking like the accuracy is a little bit less, and then the reaction time is a little bit delayed as well. And if you think about, if you have a intact body schema, if we could go with that theory of how this works, your accuracy would be quite good, and you wouldn't take a lot of time to be able to figure out right or left. But if it's impacted in some way, there's a possibility that could be responsible for some of the delays, as well as the impacted accuracy or diminished accuracy. And a lot of speculation in there, but a quick dive at the the data set is looking like there's going to be something there, but what that is attributed to, we have to have a little more time to really tease out.
But for those people that don't know about the NOI and the left-right thing, can you just give us a little bit more understanding about, I'm just thinking as a therapist, what does this mean, and how do we help people if a problem is detected?
Yeah, well, a couple of things. So what does it mean? My brain goes to what has the science suggested so far? Because I think there's still some unanswered questions and some controversies out there in terms of what it means. In the studies that have looked at acute pain, it's quite interesting that the side where the pain is happening, where it's experimentally induced, there's no change in accuracy or reaction time on that side. It's actually the unaffected side, the side that doesn't have the induced pain, where there's a delay. And what that would suggest is that, and what's been hypothesized is that there's a bias towards this new pain. There's this bias towards this acute pain, that we're kind of inhibiting any information about the other side, which would make sense. And I think that's why the theory kind of bubbled up. But in chronic or ongoing persistent pain, there's actually kind of a reverse phenomenon of the affected side, the side that has this ongoing persistent pain state, is delayed. In fact, the thing that's been studied the most is complex regional pain syndrome, and it's significantly delayed the ability to recognize the side that is their usual side of pain. So possibly quite different mechanisms are at play for acute and chronic, and we'll need, at least in this breast cancer study, to look at timing since how long has the pain been around, how long ago was the treatment. The thought is, if there is a diminished, if it's an ongoing persistent pain state and there's a diminished capacity to do this recognition task, that practice with it actually activates areas of the brain, like the premotor cortex, associated with movement of that body part, which theoretically can be a part of then the therapy for, it's a stage in kind of a graded motor imagery package that is very lower level activation of the brain associated with movement of that body part, which theoretically would be a good thing to do if it's not triggering their pain. And then you could build up to actually participating in movement in various ways.
I would just congratulate you on looking at assessing impairments, because that study for breast cancer survivors is really lacking. And so we've looked at dysfunction and measures of dysfunction, but that doesn't tell us where the problem is. And when I hear you talk about that, then I think that, but if there's an altered sensation where the nerves have truly been damaged, irreparably damaged, then this, even though, and this is just, thinking off the top of my head, if we then develop an intervention, then the intervention is most likely going to be a management strategy, because there's the underlying issue there all the time.
Yeah, it's interesting, like don't really understand what would drive these cortical body schema changes. And from the periphery, if there's this altered amount of or type of information coming from that part of the body because of nerve damage, then I think that can be a peripheral mechanism that would drive, and this is speculation and theory here, but would drive some of those cortical changes or those representational changes, as well as there's bigger meaning here to that part of women's bodies that go to sexuality, go to mothering and body image, and so there's probably also some top-down effects of beliefs, understanding, and values and self-image that are driving potentially some of these cortical changes, assuming that's underlying, if we could measure this clinically. So in that circumstance where somebody might have long-standing nerve damage that's not likely to self-repair, or the body can't manage that repair, I wonder if there isn't some strategies that would kind of tackle things from top down as well, some knowledge, some de-threatening of this, so that it doesn't become this persistent pain state, despite the fact that there's this altered sensation. And the treatment target might be those representational aspects of the motor pathways and the sensory pathways within our brains, as well as maybe some peripheral things like mobility and desensitization training can help, I would think, with that too. But that's where my brain goes from what you were saying in terms of that long-lasting impairment that we may not be able to change within their tissues.
Ben, I'm really excited that you're doing this work. So the more that we think about impairments and that we talk about impairments with the health professionals and the breast cancer survivors, it means that we're then looking instead of not being aware of what the problems are. So congratulations again. Can you just let us know what are you up to in the research, and what's the thing that you're working on now and the next bit?
Yeah, I think the immediate stage for this data set we have is we have to get out what is normal for even doing this left-right discrimination task for this new area of the body that hasn't been tested before. So that's be a foundation to be able to say, okay, if somebody were to test this in an individual, how does it stack up? Does it look like there's any impairment that we could then design something to treat that? I think that's step one, as well as then immediately following that, well, what did we get from this study in this big cohort of women post breast cancer treatment? I think that's all great to try to figure out what's happening, but really our ultimate goal is to understand that better so that we can make some suggestions for treatment, test out in some clinical trials, to really help refine the decision-making process of, well, what do we do about it? Because it's great to know a little bit more of what might be happening in these links between the peripheral and the central changes that are often driven by that experience. But ultimately, it's about how can we help? And I think that would be the next step. And I don't know where that will actually, what that will look like yet. And I think a little bit, probably the beginning of this next year will help us really figure out the next steps and for us to do, but then also to put out there for others to do, because there's only so much our research group can tackle. So.
Exactly. And what I like about this, the methodology of the summit, is that we can float out early thinking, early, and also then hopefully get that cross thinking. So I would be thinking that if there's anybody out there listening and going, yeah, I know what he's talking about, and I've seen that, and I've done this, then I'm sure that they could easily get in contact with you, Ben, just to put that feedback back in.
Yeah, I'd love it. I think that technically the survey is still open. We'll probably close it at the beginning of the new year. But in terms of what guides the next step, some of it will be data driven, but others will be conversations with clinicians, conversations with other researchers that will prompt the next. And I love that aspect of kind of scholarly efforts and research. It really, I think, should be driven from both the clinicians on the front lines as well. So we have to have those conversations. So yeah, please reach out to me. I'm happy to chat about this anytime.
Lovely. Thanks very much for your time today, Ben.
Absolutely. Thanks for having me. Appreciate it.